I'm Dr. Mohsena Sayed, consultant neurologist, Department of Neurology. The topic of today's lecture is cranial nerve examination. Now, the objectives of this lecture is to learn the cranial nerve functions, to demonstrate how to perform the cranial nerve examination, and to apply the clinical skills to identify normal cranial nerves and to differentiate it from diseased ones by using the clinical skills. Okay, as you all must be knowing that there are 12 cranial nerves. The first cranial nerve is the olfactory nerve. This is a picture of the cerebrum and the brainstem showing all the 12 cranial nerves. The first one is the olfactory nerve that carries the sense of smell through the olfactory nerve to the olfactory tract and then to the olfactory bulb. This is the olfactory bulb. Then this is the second cranial nerve, which is the optic nerve that carries the vision. The nerve forms at the retina and then it passes through the optic canal to the optic chiasma. And from here, the optic tract forms after the decussation of the fibers and it moves to the thalamus. And from there, the optic radiations move to the primary visual cortex and the occipital. Now, there is the third cranial nerve, the oculomotor, and the fourth trochlear. These both nerves lie in the brain. Then there is the largest nerve, the trigeminal. Then sixth, the lucent. Seventh, facial, and eighth, vestibulocochlear. These four lie in the pons. And the ninth cranial nerve, that is the glossopharyngeal, the vagus, 10th, and the 12th, hypoglossal. These three lie in the medulla. And the 11th cranial nerve, SSL, is unique in a way that it does not start from the brainstem. It actually gets fibers from the cervical spinal cord from C2 to C4 vertebra. And the fibers enter the cranium through the foramen magnum and join the fibers of the vagus, and then they travel back along with the vagus to the jugular foramen and in the way the trapezius and the sternocleidomastoid. Now the examination steps. First of all, you will start with the greeting. Whenever you do any examination, you always start with greeting. So first you greet and you introduce yourself, you ask the patient his name, and you explain the procedure, what are you going to perform. You tell them that you're going to perform this examination on them. You ask for the permission to start the examination. Okay, you ask the patient to sit on the edge of the couch or a chair, approximately 1 arm distance away. You wash your hands. First, you look at the face and observe for any facial asymmetry, proptosis, ptosis, or any parotid swelling. And you also ask the patient if he has any pain somewhere. Then you proceed to individual cranial examination. Okay, so the first cranial nerve is the olfactory nerve. Olfactory nerve is concerned with the sense of smell. First, you will ask the patient about any change in his sense of smell. Then you will check the patency of each nostril. For this, you need a cotton wisp, and you first block one side of the nostril and ask the patient to blow air on the cotton. What happens when the patient blows air on the cotton? If the nose is patent, the cotton wisp moves. This shows that the nostril is patent. So you check it on one nostril and then on the other side. Then you check for the sense of smell. For this, again, you need to approve one nostril with the finger and ask the patient to close the eyes and check for individual familiar odors like coffee, orange, and mint. The patient is able to tell, then his sense of smell is normal. Otherwise, if the patient is not able to tell, then he must be having some anosmia. Then the second cranial nerve. Second cranial nerve, the optic nerve, is concerned with the sense of vision. And the examination includes the pupil examination, visual acuity, visual field, color vision, and the fundus examination. Okay, when you first of all the pupil examination. Examination, you need a dim and you test each eye separately. First, you see the pupil for and check it for the size, shape, and symmetry. Then you place one hand over the bridge of the nose. As shown in the picture over here, you just put your one hand over the bridge of the nose to prevent the illumination of the eye. And then you shine a bright light on one eye and look for constriction of the pupil. We check two reflexes over here, the direct light reflex and the consensual light reflex. For the direct light reflex, when we shine the light on one eye, we look for constriction of the pupil on the same eye. This is the direct reflex. But for the consensual light reflex, we throw the light on one eye and we look for the constriction of pupil on the opposite eye. So first you check the direct and indirect or direct or consensual light reflex in one eye, and then repeat the same examination on the opposite eye. Okay, then there is a swinging light reflex. Now the swinging light reflex, what we do, we throw the torchlight on one eye and simultaneously, within seconds, we shine the light on the opposite eye. Like you throw the light on one eye and within seconds on the opposite eye, and we repeat the procedure, swinging the light this way again and again for 3 to 4 times until you see the pupillary response. Now, this is important in certain diseases, like when there is some optic nerve pathology on one side. What happens when you throw the light on the normal eye, the normal pupillary response is constriction. As you can see in this picture, the normal pupillary response is constriction. So the pupil constricts. But when you swing the light on the opposite side, which is diseased, the pupil instead of constricting dilates. And when you continuously swing, the normal pupil constricts, the abnormal dilates. Why this happens? Because there is a sensory afferent deficit of the nerve which is damaged. This is known as relative afferent pupillary defect, also known as the Marcus gun. So this is important to detect optic nerve dysfunction. Then we have a accommodation reflex. This is part of third nerve, but done with the pupils. So we place a finger 10 centimeter in front of the patient's nose and ask the patient to look at a distant object, any point on the wall. And then you ask the patient to look at your fingers, first at a distant object and then immediately at your fingers. What happens? The eyes will adduct and there will be constriction of the pupil. This is known as convergence retraction reflex. Now the visual acuity. For visual acuity, we usually perform this with the help of a Snellen's chart. This is the Snellen's chart. There is some letters written with different sizes and a numbering is given with each size of the letter. We test each eye separately and we close one eye and then test each eye. It can be tested in several ways. For the far vision, usually the Snellen chart is placed at a distance of 6 meters and we ask the patient to read up to the lowest possible line. And for the near vision, we usually hold it at an arm distance and again ask the patient to read up to the lowest possible line. If the patient is able to read up to the lowest possible line, we mark it as the visual acuity as 6 by 6 because the patient is able to read it up to the distance of 6 meters. But if the patient is unable to read the largest letter, we ask them to count fingers. We show the fingers and ask them whether you are able to count them or not. If they are unable to count fingers, then we wave the hands in front of them like this. And if all the occasions fail, then we shine the torch light in the eye and see for any visual response. If the response is present, then we say that the light perception is present. If there is no response, then we say no visual perception to light. Okay, now the visual field. For the visual field, we usually perform this by confrontation method. We ask the patient, first the patient and the examiners should be at the same level, at an arm distance, and we ask the patient to look with both eyes at your face. you put the hands on both sides like this, and approximately 50 centimeter apart, should be midway between the patient and the examiner, and approximately 50 centimeter apart. Now, like shown in the picture as well, first your fingers should be in the patient's upper temporal fields on both sides. You wiggle your finger and ask the patient which finger I'm moving, or the fingers moving in which hand. Then you simultaneously move both fingers and ask the patient whether he's able to appreciate or not. Similarly, you will place the fingers in the lower temporal fields and ask the patient where, if he's able to tell which finger is moving. Then there is the major visual field is normal. This is basically not the part of cranial nerve. This is actually to detect the dysfunction in the parietal lobe, also known as visual neglect or visual inattention. Then we test the visual field in each eye individually. Again, the patient and the doctor sit at the same level at an arm's distance, and we ask the patient to cover one eye and also close the doctor or the examiner closes one eye on the same side. If the patient is covering the right eye, you will cover your left eye. So should be same on the same side, causing a mirror effect. Now ask the patient to look at your nose with the uncovered eye, and then you bring your index finger from the periphery to the center and ask the patient to tell when he starts seeing your finger, your moving finger. First, you test it in the horizontal plane, then upper quadrant, and then in the lower quadrant. But your fingers should be midway between you and the patient. First, you test all three planes on one side, then on the other side, and then repeat the same test for the opposite eye. So you'll be able to appreciate the nasal and the temporal fields on both eyes. Now, the assessment of the blind spot. For the blind spot, again, the patient and the doctor or the examiner should be sitting at an arm distance, and ask the patient to look at the tip of your nose and close your respective eye as you did in the visual field examination, and take a red-headed pin like this and start moving it from the periphery to the center, and ask the patient to tell when the pin disappears and when it reappears. Now, the blind spot is normally found just temporal to the central vision at the eye level. So the disappearance of the pin and the reappearance of the pin should be at the similar point for both the examiner and the patient. So this way you can assess the blind spot. Now, the color vision. Usually performed with the help of an Ishara chart. This is an Ishara chart. We show different colors to the patient, and we ask to name different colors. Usually patients are shown red, blue and yellow colors, and we detect it for the color blindness. Now, the fundus examination. Now, for the fundus examination, you need a fundoscope. Should be performed at dim mood, the first turn off the lights, and then again sit opposite to the patient. Ask the patient to focus on some distant object, and then we will check first the right eye and then the left eye. For the right eye, the ophthalmoscope or the fundoscope should be held in a right hand, and the examiner will examine with the right eye. So you will start approaching the patient from the right side, and for about 30 centimeter away, and start focusing on the pupil. When you throw the light on the pupil, it appears pink. This is known as red reflex. And when there are certain opacities or cataract, what happens? The red reflex is absent. So first you just throw the light on the pupil, reflex is present, then you start focusing on one eye starting from the periphery to inside and follow the blood vessels. The blood vessel will converge on the optic disc. Then you will examine the optic disc for the venous pulsations and the disc margins. Also look at the color of the disc. This should be pink color normally, and the margins should be clear, crisp, If there is blurring of the margin or the color is not pink, instead it's pale, then there is some pathology, like could be optic atrophy or papilledema or papillitis. Then we repeat the same test for the opposite eye. Now the 3, 4, 6 cranial nerves, oculomotor, trochlear, and the abducent. This is concerned with the conjugate eye movement. Now for this, again, examiner shall sit 1 meter away from the patient on a chair. First, you just show the patient your finger and ask to focus on the finger and note for the resting position of the eyes and position of the primary gaze. You look for any eyes deviation or restriction of eye movements or any nystagmus. And also you look for any drooping of eye, like ptosis. And then you start moving your index finger or a pin. Should be midway between you and the patient, and you ask him to follow it with your eyes. You will give him 2 commands. You will ask him to follow it with his eyes without moving his head, and also ask them to report for any diplopia or double vision. Now you keep moving the finger in all directions. You make an H. How you make an H? You move the fingers to his right, then upwards, then downwards, and then towards the left, then upwards and downwards. In this way, you make an H figure and you assess all the 3 cranial nerves and the extraocular movements in all directions. Now the trigeminal nerve. Trigeminal nerve is concerned with the sensations over the face and with the chewing. Okay, now we ask the patient to close the eyes and check for sensations. 3 sensations we are going to check, that is the light touch, the pain sensation, and temperature. For the light touch, we take a cotton whisk and first we give a reference to the patient. We touch the sternum with the cotton whisk and tell the patient that I'm going to touch this cotton whisk to your face, and you will feel like this. When the patient gets the reference, then you will start examining with the cotton whisk over the forehead. At the forehead, you will be checking the ophthalmic division, then the cheek for the maxillary division, and the jaw for the mandibular division. You check on one side and immediately compare for any difference on the opposite side. Then you repeat the same test with the sharp pin for pain sensations. And then for temperature, you will use a cold metallic tubing fork. And always compare on both sides. Now the corneal reflex. Now corneal reflex is a painful procedure. Whenever you proceed to the corneal reflex, you take permission from the patient and you explain the procedure to the patient. Now you ask the patient to look up and outside like this, and then you touch the sclerocorneal junction here. You touch the sclerocorneal junction with the wisp of cotton. There should be reflex blinking of both eyes. This is a normal corneal reflex. So you check for the blinking of both eyes simultaneously once the sclerocorneal junctions is touched. Now the muscles of mastication. First we will check for the masseter and the temporalis muscle. We inspect the temporalis muscle with the temples and the masseter muscles, which is on the posterior jaw. And first we just inspect and look for any evidence of wasting. Then we palpate the both muscles, the temporalis and masseter bilaterally. How we do this? We ask the patient to clench the teeth like this, and we palpate the temporalis and masseter simultaneously and look for any wasting and the muscle contraction. We feel for the muscle contraction and also for the wasting like this. When the patient clenches his mouth like this, you can feel the muscle contraction and also the wasting. Then the pterygoids. Pterygoids, we ask the patient to open the mouth against resistance. First, you place a hand below the jaw, as also shown in the picture, and you place the hand here, and give some resistance and ask the patient to open the mouth. When the patient opens his mouth against resistance, if he's able to perform, pterygoids are normal. But if there is some weakness, the jaw deviates towards the weak side, or the jaw the patient is unable to open the mouth. Now, the jaw jerk. For the jaw jerk, you ask the patient to slightly open his mouth like this. And then you place your index finger over the patient's chin and strike it with a hammer with a minimum force. Normally, there is minimal closure of the mouth. This is normal response. But if it's a brisk closure of the mouth, this is a brisk jaw jerk, and which is pathological. Normally, jaw jerk shouldn't be brisk. It should be just normal or minimal closure. But if it's a brisk jaw jerk, it is pathological in case some upper motor neuron type pathology. Next is the facial nerve. It is concerned with the facial expressions and taste of anterior two-thirds of the tongue and soft palate. For the taste sensation, again, you will have to take permission from the patient. You have to explain the patient that you're going to perform the taste check test. Ask the patient to stick out the tongue and gently apply a few drops of different solutions over the anterior part of the tongue to test for the sweet, sour, and bitter taste one by one. We give usually sugar solutions, salt solutions, bitter tongue solutions, and check the taste. Then, for the facial expressions, we look at the symmetry of the face, and we look at the nasolabial folds over here, and we look for the forehead wrinkles. Also, we look for any spontaneous movements, and we ask for hyperacusis. What happens in hyperacusis? There is weakness of stapedius muscle, and hence the patient appreciates sounds louder than normal. After the inspection of the face, we ask the patient to do the following movements. First, we ask them to make the creases over the forehead. We ask them to make the creases, or we just ask them to look at the roof. Then we close the patient's eyes tightly like this, and we ask them to close them tightly and don't allow the examiner to open. Then we ask them to blow out their cheeks, and then we ask them to show the teeth. And when the patient is showing his teeth, we check for any deviation or drooping of angle of mouth. The weak side usually droops. And we also ask them to whistle. Now, the importance of facial nerve is that we have to see or check whether the whole side of the face is weak or only the upper is spared and lower is involved. If the whole face, the upper and lower face is involved, this is known as lower motor neuron type facial palsy. But if only lower face is involved and the upper face is spared, this is known as upper motor neuron type facial palsy. So you have to check for the deficit, and you have to also establish whether the weakness is upper motor neuron type or the lower motor neuron type. Now the vestibulocochlear nerve. Vestibulocochlear nerve has two components. One is the cochlear part, which is responsible for the hearing, and the other one is the vestibular part, which is concerned with the sense of balance. There are three methods to check the vestibulocochlear nerve: the whisper test, Rings test, and the Weber's test. First, we will perform the whisper test. For this, the examiner stands behind the patient, usually 60 centimeter behind, and asks the patient to close his eyes. And first, you will block or mask the other ear with the hand. Like you can see in the picture, you will block or mask one ear with the hand, and then you will whisper few words or letters in the other ear. First, you will explain it to the patient that I'm going to whisper a few words in the ear, and then you whisper them in one of the ears. and then you ask the patient to repeat those words. Then repeat the same test or same procedure in the positive ear, and normally the patient is able to tell what you have whispered in the air. Then the hearing is normal. But if when the hearing is normal, we do not proceed with the release and webers. But if the hearing is affected, then we proceed further to the release and the webers test to establish whether there is sensory neural hearing loss or the conductive hearing loss. Now for the release test, what we do, we take a tuning fork. Usually a 512 hertz or a 256 hertz tuning fork is used. We take a vibrating tuning fork and place it on the mastoid process over here. As you can see in the picture, you place the tuning fork on the mastoid process and ask the patient to tell when the vibration stops. As soon as the vibration stops, we bring the tuning fork here in front of the external meatus or near the external meatus and ask the patient if he can hear it or not. Normally, the air conduction is checked at the external meatus and bone conduction is checked at the mastoid process. And normal hearing, the air conduction should be better than the bone conduction. This is known as a release positive. Any normal person will tell air conduction better than bone conduction. So when you put the vibrating tuning fork at the mastoid, patient will tell you when the vibration stops. You put it here, patient will be hearing. This is known as release positive. And if the process is reversed, then it's release negative. When the bone conduction is better than the air conduction, it is known as release negative. Then we perform the Weber's test. For the Weber's test, we place a vibrating tuning fork over the forehead and ask the patient to tell from which ear he hears louder. In normal hearing, the patient should be able to appreciate normal or equal hearing in both ears. But if there is conductive deafness, the test lateralizes to the diseased ear. And in the sensory neural deafness, the test lateralizes to the normal ear. When you perform all the three, whisper, release, and Weber's test, now after interpreting the results of all the three, you are able to tell whether the patient has a conductive deafness or a sensory neural deafness. When the ear conduction is better than bone conduction and the Weber's is lateralized to the normal ear, it is said to be sensory neural deafness. And if the bone conduction is better than ear conduction and the Weber's test lateralizes to the diseased ear, it is said to be a conductive deafness. Now the glossopharyngeal and the vagus nerve. Now glossopharyngeal and vagus nerves, they function together, and both of them are concerned with swallowing, inflammation, guttural and palatal articulation. Glossopharyngeal nerve also carries taste of posterior 1/3 of the tongue, but it is rarely tested. Whereas vagus nerve is concerned with the motor supply to the pharynx, larynx, and the palate. Okay, for the glossopharyngeal and vagus, first we will check or assess for the patient's speech. We ask the patient to say few words, and we look for patient's speech quality. We look for any nasal quality to the speech, or any slurring of speech, or hoarseness of voice. After assessing speech, we ask the patient to swallow or drink few sips of water and check for the swallow. While the patient is swallowing, we will observe for any choking and also for nasal regurgitation. Now, after swallowing, we will perform our test for the palatal movement. To ask the patient to open the mouth and look for the position of the uvula. Here, the uvula should be central. We look for the position of the uvula and the palate, and we also take a spatula and depress the tongue and ask the patient to say ah and then observe for the palatal elevation. Normally, when the patient say ah, the palate should elevate symmetrically on both sides and uvula should be central and elevate again. If there is some pathology on one side, uvula deviates to the normal side, and the palate droops or does not elevate on the disease side. Now we check for the gag reflex. The sensory component goes through the glossopharyngeal nerve and motor component through the vagus nerve. Assess the gag reflex by gently stroking. Okay, first of all, when you are assessing the gag reflex, this is again a painful procedure. You have to explain the procedure to the patient and you have to take the permission first, and then you will start with the gag reflex. So first, you will ask the patient to open mouth, and you will take two spatulas. First, you will depress the tongue with one spatula and gently stroke the soft palate on each side with the other spatula. When you strike the soft palate, what happens? The palate elevates. Normally, the palate should elevate symmetrically on both sides when sustaining an R, and also in response to stimulation on both sides, and uvula should always be central and elevate along with the palate. Okay. Then one more thing, we will check for the cuff reflex. We ask the patient to cuff and check for the normal cuff. We will see for the cuff that is the quality of cuff is normal, shouldn't be weak, and any bovine quality. So we will look for it. Then we will proceed to the accessory nerve examination. Now, the accessory nerve innervates the trapezius and the sternocleidomastoid muscles. Trapezius muscle is responsible for the shrugging of shoulders, whereas the sternocleidomastoid helps in turning the head laterally to the opposite side. Okay, so for trapezius muscle, we stand from behind and look for any atrophy of the muscles. And then we place our hands over the shoulders and give some resistance and ask the patient to shrug the shoulders or raise the shoulders against your resistance. If the patient is able to shrug the shoulders, then the trapezius is normal. But if the patient is not able to shrug the shoulders or the shoulder droops, then there is weakness of the accessory. And for the sternocleidomastoid, again, we will first inspect for any atrophy of the muscles. This is the sternocleidomastoid muscle over here. So we look for the atrophy of the muscles, and then we place the hand on one side of the face and ask the patient to turn the neck or the head against the resistance of your hand. And we will feel the bulk of the muscle on the opposite side. Like placing the hand on this side, ask the patient to turn the head towards your hand, and you will feel the bulk of the muscle on the opposite side, because sternocleidomastoid turns the head on the opposite side. It works on the opposite side. So if the right side is working, the head will tilt on the left side. If the left side is working, the head will tilt on the right side. So it usually, so we palpate the sternocleidomastoid on the side opposite to the head turn. Now the last cranial nerve, which is the hypoglossal nerve. Now this hypoglossal nerve is concerned with the motor innervation of the tongue, or motor function of the tongue. First of all, we will inspect the tongue. We will ask the patient to protrude the tongue and observe for any tongue atrophy or any enlargement or dilation. Then we ask the patient to push the tongue into each cheek, like this. We ask the patient to put the tongue into each cheek against resistance. You apply the resistance on one side, and patient will push the tongue onto the cheek against the resistance. And then you will check it on the other side. This is to check the power of the tongue. And then you will ask the patient to move the tongue quickly from side to side like this. So patient will move the tongue from side to side to be able to assess. If the tongue is weak from on one side, it usually moves towards or deviates towards the weak side. So after completing the cranial nerve examination, uh, we explain to the patient that the examination is now finished. We thank the patient for their time, and we wash hands. Never, examination is never completed if you don't greet the patient and you don't tell the patient and thank the patient. So this is a very important step after completing the examination. Always thank the patient for their time. Explain them that the examination is finished, wash your hands, and then you summarize your findings, clinical findings. Okay, so these are some video links for the suggested video links for cranial nerve examination. As I've already discussed all the cranial nerve examination, you can view these videos, and this will further help you in enhancing your examination or making your skills more perfect. And this is a checklist for cranial nerve examination. A quick review. First, wash your hands, then introduction, then patient's name, explanation of the procedure, consent taking, exposure and position, then start with the inspection. First nerve is olfactory nerve. For olfactory nerve, we check two things: the latency of the nostrils and individual smells. In the optic nerve, we check the pupils, direct and indirect, accommodation reflex, visual acuity, color vision, visual fields, blind spot, and fundus. For the oculomotor, trochlear and abusive nerves, we check the extraocular movements and the pupillary light reflex and accommodation, which is actually part of the oculomotor. Then trigeminal nerve, we check sensations in all three divisions. In motor examination, temporalis, messages, and pterygoid muscles, jaw jerk, and the corneal reflex. Facial nerve for the muscles of facial expression, corneal reflex, which is again part of both the fifth and the seventh nerve, hyperacusis, and taste and anterior tooth lobe of tongue. The vestibular cochlear nerve for the whisper test, Winnie's test, and the Weber's test, glossopharyngeal and the vagus, speech examination for dysarthria and dysphonia, R test for the movement of palate and uvula, swallow test with sips of water, gag reflex, and the cuff reflex. Accessory nerve to assess trapezius and sternocleidomastoid muscles, hypoglossal nerves to inspect the tongue and the power test. Thank you. This is the examination of the cranial nerve. If there are any questions, you may write in the chat box.